Thank you so much for having me, and it's always great to be able to join groups of people who are coming together essentially to change a disease process that we've really had a lot of difficulties treating over a number of years. And one of the major themes of my talk today is going to be really that we're in this together, and it really does need to be a team-based approach to be able to get the best outcomes for our patients. I'll try to keep as practical as I can, and I hope our discussion at the end will be very fruitful. And so I'm going to talk a little bit about the practical shock management in the modern era. So what are the objectives? I'll try to be brief in the 30 minutes that I have with you. Why is cardiogenic shock hard to treat? Why is it hard to study? Why do we think about using shock protocols and teams to get better outcomes? And how to practically start a shock team. And I'll share a couple of cases and who was called within these cases and how we manage this within our center. And every center is going to do this slightly differently. I'll be very brief on this background information, but really cardiogenic shock, despite all of the different types of causes, is typically broke down into two major phenotypes: an acute shock state or a more chronic decompensated heart shock state. It can manifest itself as predominantly LV dysfunction or RV dysfunction. Typically, when severe enough, RV dysfunction will cause LV dysfunction, and LV dysfunction will cause RV dysfunction. And what it really does is it starts this neurohormonal cascade, which, if left untreated with the development of multi-system organ failure, is really, really challenging to survive from. And that's why, statistically speaking, the shock mortality has hovered somewhere in the 50% range for AMI shock and somewhere around the 30% range for decompensated heart failure and cardiogenic shock. Now, what's important here is that the incidence of both AMI and non-AMI cardiogenic shock is slightly increasing. This is likely from an elderly patient population with more comorbidities. Our use of hemodynamic support devices, though it's growing, is still predominantly controlled in more academic institutions or larger community-based programs, and is not necessarily widespread within the community. And in particular, even if the devices are available, the expertise of managing and taking care of these patients is sometimes lacking, but in general is growing over the course of the last 5 to 7 years. I alluded to this earlier, but there's two major phenotypes in cardiogenic shock, and I don't think we can actually talk about shock teams and their importance and the practical knowledge it takes to run a shock program until we really identify that there's two major different components to these shock patients, because they're treated really differently. So the patients who present more chronically are patients with decompensated heart failure, and they're used to low cardiac outputs, and they may come in decompensated because of worsening shock, missing their medications, lots of different reasons. But the major component with these patients is that they have compensatory physiology. So they tend not to need so much support up front. They do reasonably well with inotropes, with smaller devices like a balloon pump. And then when they really are sick and they need you to take over their heart and potentially bridge them to LVAD and transplant, then they need really complete support. And so really there's not a big role for intermediate devices in heart failure and cardiogenic shock. On the right-hand side of your screen, you see the AMI shock patients, and they have typically a higher mortality, typically around 50%. And these patients have no compensatory physiology. And so their end organs are used to seeing a higher cardiac output. And so when they come in sick and they're ill and their cardiac output is low, they tend to need intermediate device early and upfront. They typically do not need full, complete hemodynamic support, but 10 to 20% of patients will need that, even presenting acutely. But because they don't have compensatory physiology, they tend to need hemodynamic support to be able to reverse their end organ failure. And that's the classic AMI cardiogenic shock. So these two different groups are really important to keep in mind, and I'll be referring to them a lot throughout the rest of the talk. So we all know that revascularization helps AMI cardiogenic shock, and that's not the purpose of this slide. The purpose of this slide is that small box in the right-hand corner, that this randomized control trial that proved that revascularization helped to improve outcomes in AMI cardiogenic shock was published in 1999. And what's really important is that there was a lot of work that was done to get to that point. So 12 years earlier, Bill O'Neill, who's my friend and mentor, was doing work at the University of Michigan, where he and his fellow were doing interventions in AMI cardiogenic shock, and they noticed an improved mortality from about 80% of people passing away to get about 50% of people passing away. But again, the purpose of this slide is to really get that bottom date there, which is 1987, 12 years earlier. And so what was happening within this 12-year period of time? Well, STEMI systems of care were being built. People were getting more experience and understanding with STEMI care, with coronary intervention. And so all of these different things were coming about. And it took about 12 years to get to that point. So way back in 2015, when we started the Shock Initiative, now 8 years ago, we started to develop this idea, and we told people early on that it will take about 10 years for us to get a randomized control trial to be able to prove to everybody else that this was probably the right way of treating patients. And we're really sticking to that timeline pretty well. But what have we done in the meantime? Well, we've really built this concept and understanding of shock teams, shock protocols, the pitfalls and the benefits of hemodynamic support. And I think very similar to STEMI systems of care, MCS systems of care are really taking shape throughout the country. And so, again, I applaud you for being considerate of this topic, for organizing to be able to take care of these patients locally, because I guarantee you that patients definitely appreciate having state-of-the-art care close by. So let's shift gears a little bit. I just wanted to give you a little bit of background information, but I'm sure throughout the symposium that will be delivered to you a little bit more. What I really wanted to get across to you is, why is this important at all? You know, why do we consider starting a shock team, and what are we going to potentially gain from it? So the first thing is that these are potentially hard patients to take care of. So a clinician needs to have the ability to interpret, understand advanced hemodynamics. They need to be able to actually put in these pumps, so managing them, making sure they don't have bleeding and complications. And then typically these patients need other interventions. You may need to do a complex coronary revascularization, structural procedurals. You may need to have peripheral interventions for closure of these devices. And then a backdrop of heart failure is really important. Now, it doesn't mean that everybody needs transplant and LVAD, but partnering with institutions that have those devices to offer those select patients who need those devices is something that's really important. And so it is really an important aspect to have a team, but to Michael Jordan's point here, there is a little bit of individual skill set that is really important. And you do have to have the abilities to take care of these patients and to have those individual skill sets and potentially collective skill sets to be able to do as much as you can to take care of these very complex patients. The major benefit, though, of having a team is to really share the blame, which is not the nicest way of saying it, but because these are really the sickest patients that come into the hospital, right? I mean, 1 in 2 of AMI shock patients are going to die. And so, you know, it can be costly. It can have an emotional toll on our nursing staff, on physicians, on the entire medical community. When things become futile, when you're not helping a patient, it's hard to potentially have those conversations as just an individual. And then if there are administrative hurdles that need to be overcome, it's really better to do this potentially as a team. And to be honest with you, no one can do this for a long period of time from A to Z. And the people who have tried have epically failed, quit medicine, got burned out, and it's really important for us to think about the longevity of our programs and teams when talking about taking on cardiogenic shock the way that it needs to be. Now, we can talk about devices, right? We can talk about balloon pump, Impella, tandem heart, VA ECMO, and in fact, probably all of them have a role in shock management in different capacities. But it's not necessarily just about the device. It's really about you all choosing what's right for your patient given the unique circumstances that are present in your own institution. What do I have more experience with as an individual clinician? What does my team have the most experience with taking care of these patients in the ICU? What are the pitfalls and challenges of one device versus the other? And for any of you who do a lot of shock work and put a lot of hemodynamic support devices in, which is again just one component of shock management, but an important component, you know that they're riddled with vascular access complications, bleeding, stroke, and they tend to be very resource heavy technologies. And so it is really important to make sure that you have a system in place to take care of these very, very sick patients. Now, over and over again, the concept of shock teams has been demonstrated to be associated with improved outcomes. We showed it in the cardiogenic shock initiative, where we were able to essentially improve our mortality from about 50% to about 25%. The Innova group showed this very nicely and were, originally, very strong partners with us within the shock initiative. This has been shown in Ottawa, at the University of Utah, and lots of other places. Now, what brought about this shock team? Well, over the course of the last 20 years, we've only had about 2,000 patients randomized in trials. And so we don't have a lot of randomized control trial data on the use of hemodynamic support devices. Nothing actually has been done very well and in terms of being well powered to give us an answer. The single trial that's been done is the balloon pump shock 2 trial, which was done predominantly in Germany. And so we have all of these tools. We don't have robust data for any one given device in any one given scenario in terms of a randomized control trial, but I think we've all seen how important these devices are and what they can do to our patients. And I think we have all been influenced by the observational data that we've seen and that we've experienced. And so that's where the shock team essentially evolved from, which is that these patients, we should talk about them. We should think about what we can do in our own institution to give them the best chance of survival. Now, it's not just about creating a team, but the components of the team. So the components of the team really revolve around activating the team early. So somebody has cardiogenic shock, so we're going to treat them quickly. The same way that we treat patients, for example, that have STEMI. Every patient is different. A more chronic heart failure patient, maybe we're just going to talk about that patient now, come up with a game plan and assess that patient over 2, 4, 6 hours. In an AMI shock setting, clearly they're coming to the cath lab and we're activating the team and we're potentially doing more earlier on. But regardless to say, we get everyone motivated to treat these patients quickly. And so the concept of, oh man, it's 2 a.m., let's put the patient on 10 of norepinephrine and let's see what happens in the morning. That is out. You're already out of the window of managing most of these patients by the time you come in the following morning. We have a golden few hours to be able to treat these patients. And so early treatment is why shock teams work. The second thing is that shock teams tend to use more invasive hemodynamics. And so you want to get objective data. This is not just about, this is what I think and this is what you think. This is a lot about getting objective data to be able to say, what is our cardiac output deficit? What are our hemodynamics? Is this univentricular or biventricular failure? What are we objectively going to change with hemodynamic support devices? Because at the end of the day, hemodynamic support devices pump blood. And so these patients get improvements in hemodynamics. But if you don't even know those hemodynamics, then it's really challenging to say what the right device is for your patient and whether they're getting early benefit from it. Because if you wait for their kidney function to change over a couple of days, or you are just trending certain lab values, then that's really not enough information to make changes on these patients quickly. And then the other good thing about a shock team is that the futile cases tend to be identified early, and so you spend time caring for patients who have the ability to be salvaged within these scenarios. And so we tend to use more advanced hemodynamic support devices, and we tend to improve our mortality for these patients. And that's ultimately what a shock team does. But it's only if you do those components. So anybody who thinks to themselves, okay, we have a shock team, why aren't our outcomes different? We really need to make sure that we're actually running our programs in a way where we're expediting care for these patients, where we're tending to treat these patients in a likely more aggressive fashion. It's not just, oh, I made a team and now all of a sudden everything is going to get better. So let's be a little practical and let's talk about this in a case-based scenario. So this is a 65-year-old female. She has hypertension. She was at an outside hospital, 2 days of chest pain and fatigue. She's already has Q waves anteriorly, ST depressions in the inferior lead. She has a mild troponin elevation on a non-high sensitivity assay that was 0.57. Her echo shows an EF of 15%, severe MR. She develops flash pulmonary edema, gets intubated, and is clearly in cardiogenic shock. So they bring her to the cath lab at an outside hospital. She has a subacute LAD, but clearly looks like there's thrombus within the LAD, vasoconstricted RCA and circumflex. So she gets transferred to Henry Ford, and she has a heart rate of 104, blood pressure is 80/40, means of 61. She has a CVP of about 15. She's on norepinephrine 4 mics and dobutamine 5 mics. Her initial labs show a lactate that increases from 2.3 to 3.6. Her high sensitivity troponin here is greater than 20,000. So what do we do for this patient? So I bring her to the cath lab. She has a RA pressure of 15, a wedge of 26, an index of 1.94, and a CPO of 0.52. Now, clearly the hemodynamics are consistent with BIV failure. So I have a high suspicion that she has BIV failure. I put in an Impella CP. She's a rather small woman. I think that this will give her enough support, and her hemodynamics improve. Her right atrial pressure goes to 10, her wedge goes to 16, her CPO goes to 0.9. Now, if you have a shock program and you get to this point, the vast majority of programs would be high-fiving themselves, saying we got a great outcome, and they would send the patient up to the ICU, and this patient would likely have died if she went to the ICU. And the reason is that she would have started to develop RV dysfunction. She would have had higher doses of vasopressors and inotropes, and then we would have said, oh, you know what, I don't know if we want to escalate to ECMO. I don't know what we're going to be bridging ourselves to, and she may have just had a poor outcome. But clearly, if you understand that she had BIV failure and you understand that you've only treated with one-sided device, a univentricular device, then one of the things that we've slowly gained experience with our team is the concept of sitting and waiting in the cath lab to be able to decide what direction these patients are going in. So while we're suturing things in and getting everything organized, we get hemodynamics every 15 minutes and they get worse and worse. And 45 minutes, her RA pressure is back up to 15. Her PA SAT has dropped to 38%. She has diastolic suction alarms on the impella, and her CPO drops to 0.4 watts. So we clearly knew she had a high risk of developing RV failure. She had BIV failure to start. We decided to treat her with a univentricular device because a biventricular support device in her really means to put her on ECMO potentially. We didn't necessarily want to do that because she's not having a lot of problems from an oxygenation standpoint. So we place an Impella RP as well. So she's on BIV support. Her hemodynamics greatly improved. She's completely weaned off vasopressors and inotropes. We allow her to cool down for 24 hours because this was in the middle of the night at 2 a.m. And then so I brought her down the following morning and I revascularized her. This was more chronic disease within the circ and RCA distribution. We were able to just balloon and stent. We didn't have to do any kind of complex atherectomy. So we did all of the vessels potentially at the same time. She was on BIV support, and we thought that this would give her the best options of being able to get a good outcome. Now, I say this as this was a case that was before culprit shock. And honestly, the culprit, even though it was the LAD, it would be very reasonable to treat the LAD and wait for the other blockages. But the identification of RV failure was something that was really, really an important component. And for the reason that this is an important aspect of care to talk about is that if you don't have a shock team potentially, as an individual, a person who is less familiar with the complexities of cardiogenic shock could easily overlook the risk of this happening and potentially, not treat this patient as quickly as they would have. So just as a quick refresher, RV dysfunction can be defined hemodynamically with CVP, pulmonary artery pulsatility index, right ventricular stroke work index, and a CVP to wedge ratio. There's different parameters and cutoffs that you can use, but clearly this patient met that. We can treat it with multiple different devices. There's an Impella RP Flex, which can now be placed in from the neck, a Protect Duo tandem heart, as well as traditional VA ECMO as well. All have different risk profile ratios, and I'm sure you'll be discussing some of these devices later on in the symposium. But regardless, to say the important part here is that the identification was well thought of by our team, and that's why we spent some time in the cath lab to be able to decipher which direction these patients are going in, because the number one cause of RV failure is LV failure, and if you treat the LV failure, many times the RV failure gets better. But if she hadn't gone into that direction, then we would have likely just kept going with just the Impella CP device. So here's another case that I think of a patient who would likely have passed away at 99% of hospitals. So this is a patient who's 63 years old, strong family history of premature coronary artery disease. He's cutting his grass. He experiences chest pain. He has anterior STEMI. EMS activates. He has a low blood pressure. He's given aspirin, Brilinta, heparin. He comes to the cath lab. He's lethargic, short of breath. He's intubated. His systolic blood pressures are in the 60s, and they start him on some norepinephrine. And this is the value of having a team or a protocol to manage particularly AMI cardiogenic shock, which is what we did in the cardiogenic shock initiative. So this was one of the sickest patients that came to Henry Ford in the shock initiative and actually had expert care, not by me, but by one of my partners who did a fantastic job in not just following the protocol, but taking care of meticulously all of the aspects of care for this given patient. So he starts with the femoral angiogram, clearly tortuous, but large vessels that can accommodate hemodynamic support. He does this with ultrasound and fluoroscopic guidance right at the lower 1/3 of the femoral head. So excellent placement. He takes a quick angiogram, sees that the right coronary artery is open, takes a quick non-selective view of the left, sees that there's thrombus within the left main and LAD, knows that he's going to come back with a guide, stops injecting, knows this is all the information I need. I confirmed my diagnosis and I need to start treating. How do we treat? We get access on the opposite side and get ready to place an impella. This was before our knowledge of a single access as well. So the wire goes up. His patient's very sick. We don't want to inject any more into his coronaries. We know he's sick enough that actually just putting the wire in the ventricle, he had already gone into cardiac arrest. The impella CP is placed. We're going to try to do culprit vessel PCI only. We're going to guide all of our decision makings by invasive hemodynamics. The guide goes in. We see the thrombus within the LAD. The patient was already treated with just oral IV antiplatelet agents in this case. He had a TVP placed because of complete heart block. The lesion was wired and stented, and you can see that there's some sluggish flow past the LAD, but the patient isn't doing well. He has persistent hypotension. His norepinephrine dose is now at 30 micrograms per kilogram per minute. So he's clearly not doing well. Well, as part of our shock team and program, we have availability of ECMO within our cath lab. This was, brilliantly established by Dr. Cal Aliswad, who's our director within our cath lab. And one of the major components of running a good shock team and program is having all of the tools readily available. That doesn't mean that ECMO has to be done by cardiology, but it means that the surgical team is willing to come in and help place ECMO if needed at any given time, at any given hour for a given patient. So this patient, as you can see, gets ECMO placed as well. Then the operator goes on to completing the revascularization, optimizing the flow with some peripheral vasodilators, and the patient gets a Swan-Ganz catheter placed. His right atrial pressure is 15, wedge is 27, but he's on complete hemodynamic support. So even though his CPO is 0.7, his PAPI is 0.5, and he's on 10 mics of norepinephrine, this is with complete hemodynamic support with ECMO and Impella. And so how does this patient do? He gets, meticulously placed retrograde sheets to be able to perfuse the limb. He gets an advanced heart failure consult. Our palliative care team joins in, not because we're going to be making him palliative or comfort care, but so that those early conversations about what a family would want in this scenario are taken care of right from the start. And then we decide hemodynamically what we're going to do for this patient. And so he required the support devices for almost a week. The ECMO was weaned on day 7. We typically don't take both devices out at the same time. We typically will leave the Impella in for an extra day. He gets discharged to rehab on day 11, gets started on guideline-directed medical therapy. He runs 15 minutes on a modified bruise 6 months later, and his EF has improved to 50 to 55%. He is now 2 years without any hospitalizations. So a really young patient who has his full life ahead of him, who was honestly saved because we had access to all of the technology that we need to be able to take care of these patients. Clearly a selective patient who was young and had no significant comorbidities, but these are the kind of patients you want to give every chance to being able to get to a better outcome. And so what the Shock Initiative has really done is it's created a uniform shock protocol to help healthcare systems obtain predictable outcomes. And what the Shock Initiative did was it emphasized a few important points. In AMI shock in particular, your device of choice 90% of the time is going to be an Impella CP. Why? Because it's readily available in the cath lab, and it hemodynamically does everything that you would want in an AMI shock. The only caution is that there is a small percentage of patients big patients, for example, like myself, who may need more support. And so that's where you have to have the ability to possibly escalate those patients. But the treatment is the support device. And so you treat these patients with MCS early on, then you revascularize them. You revascularize them basically, ideally, with what you think is best for that patient, which is most of the time culprit vessel only revascularization. But clearly, if it's a circumflex lesion with a 99% hazy prox LAD, you're probably going to take care of that prox LAD within that setting as well. Then you use hemodynamics to wean off vasopressors and inotropes. You try to wean and escalate based on the hemodynamics. And the overall outcome is that you want to be able to get more than 70 to 80% of these patients to be alive after you've, after 30 days or hospitalization. And so that they can, we can really change the trajectory of these very, very sick patients. And so that's what we can accomplish in 2023. And that's what I think symposiums like this are really meant to be, which is to motivate us to what we actually can achieve within these patients. And if you look at the SHOCK initiative and you compare it to the studies that have been done in other trials, you see that we have, if not sicker, just as sick patients, mean lactate of 4.8, excuse me, a lactate greater than 2 of 77 in 77% of patients. The average blood pressure was 77/50, yet our 30-day survival was 68%. And the main thing in NCSI is that we actually included 25% of patients who were in stage E shock. And so those are patients who are not likely to be enrolled in the randomized controlled trial. So I argue that this is a sicker cohort than the shock trial, the culprit shock trial, or the balloon pump shock trial. And our outcomes are really, really important to consider. And I think it sets a new benchmark for where our outcomes can be. And we really need to strive to get to this point. And scientifically, we'll hopefully prove this to people in the Recover 4 trial going forward. And so our push is to make sure that we can get to over 80% survival. How are we going to do that? Try to avoid vasopressors and inotropes. These are always medications that are going to be needed. But if you're on 2 or 3 vasopressors with a support device, you have to escalate that support device. I mean, if the patient is a good candidate for that, meaning to say that they have options down the road as well. But it's really important to not rely on just vasopressors and inotropes to treat these very sick patients. You want to try to be able to achieve some certain metrics. So an AMI cardiogenic shock, to try to get a CPO of greater than 0.6 on the cath lab, to try to make sure that they don't have RV dysfunction, as I demonstrated to you in the first case. These are all important components that the shock team has to keep in mind when making these decisions. I'll end my talk here. I'll basically leave you with my email address. If I can be of any help to anybody, privately, feel free to email me, and I'll always try to do my best to help in any way that I can.